Dear colleagues, this is a minimally edited surgery of a hypermature cataract. I had several challenges in this case. Let us see the surgical steps. This is the main incision, 2.8 millimeter at around 11 o'clock. The main incision is done. We can see some blood oozing out of the posterior leaf of the incision. This is a side port incision on the right side of the main incision, and this is another side port on the left side of the main incision. And now I'm going to inject an air bubble in the anterior chamber. Beneath this air bubble, I'm going to inject dye. This is the 0.06% trypan blue dye, and as I inject the dye, the appearance of the anterior capsule becomes clear. You can see some ridges and some elevations and depressions on the anterior capsule, and now you can make out that the total capsule, the anterior capsule, is totally fibrosed. The cataract has been neglected for a very long time. The patient is diabetic and the blood sugar was not getting controlled, and he had to wait for a very long time for undergoing surgery. Now I'm trying to do capsulorhexis, trying to make a puncture on the anterior capsule. Ultimately, at this point, I have been able to make a small puncture. And now I take a Utrata forceps, hold this capsular flap and try to make a rhexis. But here at around 8 o'clock I get stuck and I cannot pull with greater force, so I stop. I ask my assistant to give me a Vanna scissor and I cut the fibrous tissue here, cross that point, take the rhexis forceps again and try to make the rhexis, but it's not moving. I cannot pull it with greater force. The geniole is going to tear off. So what I did in this case is I enlarged the side port at 8 o'clock and asked for the Vanna scissor again. And I took the Vanna scissor, engaged the Vanna scissor here, and I'm going to cut the anterior capsule like this. My idea is to get an adequate sized opening so that I can do the phacoemulsification procedure. But here I see that it's not enough. So I take the Vanna scissor again, make a cut here at around 11 o'clock and take the rhexis forceps again and try to go anticlockwise. And I find that I'm able to go anticlockwise in a zigzag pattern. So the fibrosed tissue is at some point, at other points it's not. So in the zigzag pattern I am able to go. But here at around 5 o'clock I get stuck again. And I was not able to hold properly with this forceps. So I ask for another rhexis forceps. By this time I inject some viscoelastic substance and I hold it, and as I pull, I see that the rhexis margin goes to periphery. And here I find that if I pull it further, I'm going to damage the posterior capsule. So I take the Vanna scissor again, go through the 8 o'clock side port and cut the tissue. Now I take this fibrosed capsule out and see how it is. It is very thick, very tough, and it is wrinkled. And now I try to do hydrodissection. My effort is to inject very minimal fluid because I don't know what's there in the posterior capsule. So inject very little amount of fluid at 2 points, at 1 o'clock and at 9:30 o'clock. Depress the nucleus very gently. Inject some viscoelastic substance. Now I want to rotate the nucleus with 2 instruments. If I rotate with one instrument, I will cause more damage to the granule, but if I rotate with 2 instruments, it causes less stress on the granule. And now is the time to enter into the eye with the phaco handpiece. And my plan is to try direct chop. The cataract doesn't appear to be very hard. It's maybe grade 4 plus or grade 5, but I find that the fibers are very leathery and I can see some white thing. So the posterior capsule is not healthy. It is also having some changes. The posterior capsule is lax and it is trying to come to the aspirating port of the phaco tip. I am trying to chop the nuclear fragments, and at this time I have been able to chop a small fragment and take it out. Here I hold it again and chop. The fragments are attached at a very stubborn central leathery plate which hasn't given in by chopping. So what to do? Again, inject some viscoelastic substance. By the way, I am using HPMC till now. Here I have been able to chop the nucleus and I am trying to emulsify the nucleus. Partially. Rotate the nucleus here and make a chop here at around 5 o'clock. And take a portion of this fragment. Chop it here again and take another portion of this. I'm always afraid of catching the posterior capsule. Now here I come out, and before I come out I ask my sister to inject some viscoelastic substance. Now I take 2 instruments in my hands, chopper in left hand and a Sinskey hook in my right hand. And now I'm trying to separate the two main fragments. And here I become successful in making two large fragments. So now I am finding some hope of completing the case. At this time, the mistake I did was, after separating the two fragments through that cleft, I should have injected high quality dispersive viscoelastic substance, I mean VISCOAT from ALCON, and make a space between the nuclear fragment, between the nuclear mass and the posterior capsule. If I did that, I probably could have prevented posterior capsular rent in this case. But see, I didn't do that, and the posterior capsule is coming to the port. The posterior capsule is still intact, but see what happens now. As I try to hold this fragment here and try to emulsify this fragment, see what happens. There's a rent. What to do now? I stop. I ask my assistant to inject viscoelastic substance, what is there in the trolley, that is HPMC, and slowly I come out. Now what to do? Should I enlarge the incision and take out the pieces? I thought of VISCOAT at this time. I had one or two VISCOATs in my OT, and I asked to open on VISCOAT. I heard that VISCOAT has the ability to plug this rent, and one can emulsify the nuclear fragment easily over that viscoelastic substance, that is, over the VISCOAT. The VISCOAT will push the vitreous behind. So here goes the VISCOAT through the 8 o'clock side port. Some more VISCOAT I am injecting through the 2 o'clock side port. So I am thinking that vitreous has gone behind, and I am planning to go again into the anterior chamber with the phaco handpiece. So here I am going again and trying to emulsify these fragments over VISCOAT, and I find that it is becoming possible. So the VISCOAT is still keeping the vitreous behind, and but here, as the rent enlarges, I understand that this is not the time to go ahead. I have to stop and inject some more VISCOAT if at all I want to continue with phaco. So I do that. I inject some more VISCOAT and I try to emulsify this fragment. And surprisingly, I didn't change the parameters. The flow rate is 45, vacuum is 450. And here the vitreous is behind, and I have been able to work over VISCOAT from ALCON. So the VISCOAT has saved this problem from sinking. It has prevented the nuclear pieces from sinking into the vitreous cavity. Now I enlarge the main incision for easy delivery of a multi-piece intraocular lens in the sulcus, but here also I had some challenges. I planned to deliver the nucleus over the iris, and then I found that I am injecting it in the sulcus, and suddenly the leading haptic goes into the vitreous cavity. So here I am, the leading haptic is in the vitreous cavity. It has gone behind the posterior capsule, and there's no way that I can place the trailing haptic in the sulcus without bringing this leading haptic out of the vitreous cavity. So what I do is I inject some VISCOAT, and take the chopper in my left hand and Sinski hook in my right hand, and with these two instruments I try to bring the leading haptic out of the vitreous cavity, and I have been able to do that. Now I place the trailing haptic in the sulcus, dial the lens, and I make sure that this haptic, the leading haptic, is now at around 9 o'clock position, and it is over the very tough fibrous anterior capsule. And now there is lot of viscoelastic substance behind the intraocular lens. I do not leave it like that. So I have taken my aqueous vitrectomy system, and I am doing a very nice anterior vitrectomy. I'm going through the main incision behind the IOL, and the side port is the aspiration and cutting port is towards the optic nerve, and I am cutting and aspirating the viscoelastic substance, that is HPMC plus VISCOAT mixed methyl cellulose and chondroitin sulfate and sodium hyaluronate. Everything is there behind the lens, because VISCOAT is a combination of sodium hyaluronate and chondroitin sulfate in a definite proportion. So I remove all the viscoelastic substance from behind the IOL. I keep doing cutting and aspirating, and whatever vitreous is there, that also gets cut behind the IOL. And now again the cutting and aspirating ports is towards the lens to polish the lens actually, because something was sticking to the lens, some small fragments, some particles. It was just to remove that. And now I go through the side port and cut at 12 o'clock to remove any vitreous strands if it is there. And now I'm going to inject an air bubble and then pilocarpine. After that, triamcinolone acetate. Here goes the pilocarpine to constrict the pupil, because if the pupil constricts, I will be able to understand better if any vitreous strand is there. The pupil will be picked in that area where the vitreous strands are coming from behind and coming in front around the pupil. That particular point will be picked when the pupil is constricted by pilocarpine. Here goes the triamcinolone acetate, and I want to see if the anterior chamber is free of vitreous strands or not. And I find that yes, the anterior chamber is clear of vitreous strands. So we are towards the end of the surgery. Now I just have to form the anterior chamber, inject some oxyfloxacin, and conclude the case. Hope this video will give you several tips to manage a challenging case like this in your practice. Thank you very much for your long attention.